Hi, my name is Dr. Shoaib Malik. On behalf of Maxillofacial Institute of Implantology, this lecture is about the practical application of anatomy for dental implants. So it's particular anatomy for dental implants. Before we start, um, the practical application of anatomy, there are certain things I want to make sure um, all the doctors out there understand that the goal of this lecture is to discuss and learn anatomical structure that are encountered particularly for implant surgery. The goal is not to discuss all possible anatomical structures that reside in the whole oral cavity. So we're trying to be very uh, particulate about dental implant related anatomy. And I hope you find this chapter very interesting because we did a lot of literature review to kind of build a nice picture in your head when you're doing your surgery. So you have a good roadmap of the major anatomical areas, what to expect, even if you don't have a CT scan, with the PA and pen, because you have a good understanding. But that being said, you also have to keep in mind that the numbers that we're going to provide today, after the literature review we gathered up for you guys, it still varies. In anatomy, as you know, there's a lot of variations, a lot of diversity. So some studies, let's say for example, are done in China or done in Southeast Asia or India, they might actually have a different results compared to studies done in North America or Canada or in Europe because it's due to variation of ethnicity. Same thing goes with age. Some studies that were done in young people might differ from old people, the numbers we talked about. So please keep that in mind when we go over this part of anatomy in this lecture. That being said, it gives us a good idea what to expect, or at least a mean of averages, so you know at what point we're going beyond the mean uh, in certain areas when you're so close to the mental foramen or the inferior canal or even at the sinus. I would also say that you should literally memorize this lecture. It's the foundation of which dental implantology, from my point of view as being a surgeon, is based upon. We use this to, close your eyes and know it's such by your heart that you can literally close your eyes and know where you are just by having this whole anatomy picture in your head. And if you have a good hand on this anatomy, then dental implantology becomes extremely safe and predictable. Because, when you make any mistake or your implant fails, you can take it out. You can do a bone graft. But there's certain things that makes implantology dangerous is, for example, if you go through the lingual cortex not realizing the anatomy, patient can die from hematoma. Or if you bypass violate the infraavicular nerve bundle, patient could be hyposthesia or numbness on the lip and chin, and that could affect their lifestyle for the rest of their life. But if you have a scope of anatomy, you should never, ever make those mistakes. So having these three baselines set up, let's start. So the first major anatomical structure we're going to talk about is the mandibular foramen, and every doctor in here know and deals with it literally every day in their practice because we give blocks. And this is exactly where we were aiming for. We're trying to get the infraavicular nerve bundle before it enters the mandibular foramen into the bony cavity. And the location of this becomes important, not for particularly for the dental implant, but when we start giving our mandibular block. So just to give you guys an idea about this mandibular foramen. So the goal of our block would be able to get, as you can see on the video on the right, is to have the infraavicular nerve block before it goes into the canal itself. And hence the location of the canal becomes very important, because if the canal location, if the foramen location is high, that means the nerve is entering at the high level, and the rest of it will be protected by the canal itself. So if you're giving a block that's below the foramen, you're going to miss your block, because at that point the nerve is going to be already in the bony cavity, the canal itself. So this research shows that if you're looking at the data up front, that 2.5 to 23.5% of the time, you're going to have patients whose mandibular foramen is going to be above the occlusion plane. So for those patients, if you gave them the block right at the occlusion plane, you're going to miss it. Because at that point, the mandibular foramen is above you, and the nerve has already entered into the bony cavity. So this is why, to be able to get full range of patients who in these studies have shown, we recommend going about 6 to 10 millimeters above the occlusion plane. So even at the higher level, even at those at the end spectrum of patients, you can still be able to block them because of their positioning of the mandibular foramen. So the position of the mandibular foramen is very key in giving the blocks. In relation with the occlusion plane, give us a good guideline at which point to give the block. And so to summarize this, relative to the occlusion plane, the foramen is found 2.5% to 23.5% above the occlusion plane. At the level is 22 to 47. Inferior to the mandibular foramen, you have 75 to 29.4%. So to get all the 100%, our recommendation is to be above the occlusion plane, about 6 to 10 millimeters above the occlusion plane. Hence, in both cases, if your block is at the level of occlusion, so if you're used to giving block at the level of occlusion, you have a chance of missing 2.5, 23.5, depending on the ethnicity and the different type of studies that there is out there in the literature. So again, our recommendation is to be about 1 centimeter to 6 millimeters superior to the occlusion plane. So that was the vertical aspect of the mandibular foramen. What about the horizontal part of it? So the studies have shown that if you use a 21 millimeter short needle, you are within the range to be able to in the area and be able to block or anesthetize the infraavular nerve. So in our recommendation, the 21 is the minimum side, because if you go any shorter than 21, chances are you are going to miss the block. So our recommendation is that minimum you should be able to use a 21 millimeter syringe. It's also, there are times when you're giving you a block and your patients still have some sensitivity. We also recommend infiltration of the lingual aspect of the molar region. So, for example, when you're giving your block out, what I like to do is right here, just at the lingual part right here, where the third molar is right here, just behind the third molar up here, just underneath the mucosa, I will deposit a little bit of anesthetic to kind of help numb up the area of the lingual aspect, because patients sometimes do feel that, and they have a hard time telling you where the pain is coming from, so they're just kind of jumping around, especially when they're already scared. The infraavular canal. So obviously this is one of the main things we have to be concerned about when we're doing dental implantology. And just to kind of give you some numbers, and again a nice picture in your head, and you can always come back and take a look at this lecture, which even I do at this point. You got to come back and back, because this is such an important lecture. The canal is about, in average, is about 3.4 millimeter in its wide. And the nerve inside, the bundle inside, is about 2.2 millimeter thick. That's pretty thick if you really think about it. Within the canal, there's a nerve, artery, and the vein. So the triad that travels together. The path of artery could be inferior or superior to the nerve. So within the canal itself, the artery could be on the top or below the nerve. So there is no one place you'll find. So hence, it is possible to penetrate the canal and induce a neurological damage without provoking any kind of hemorrhage. So I used to hear from some people that, hey, it's okay because before you go to the nerve, you'll have some type of bleeding. Well, that's not true, because the artery could be below it, so you could have already damaged the nerve before you even hit the vessel itself. The mandibular canal usually has a cortical bone around it. So when you're starting to drill, and as you go through the strong cortical bone and then the soft tubercular bone, you might feel some more resistance, but I would not count on it. You still should be able to definitively know how far the inferior avicular nerve is, but just for the sake of our knowledge here, just keep in mind that the mandibular canal the itself has a little strong cortical bone around it. The inferior avicular nerve travels and crosses from the lingual aspect, which makes sense as you can see, it's entering at the lingual part of the mandible. And as it proceeds anteriorly, it crosses over and then out comes out from the mental foramen. Okay, so it basically does a transverse. It enters from the lingual side and it does a little crossover and comes out on the mental foramen. Little landmarks to keep an eye on it. Obviously around the third molar, it's at the most lingual part of it, and by the fourth molar, it's right down the midway, which actually doesn't help us because we then have no protection from it, because as we're placing our implant right down the middle, and that's where usually we're going to place obviously our first molars compared to the third molar. It would be right down the middle. So you can see the nerve itself would be lingual at the foramen, crossing through transverse, and around the first molar will be right down the middle, and by the time it's coming to the first or second premolar where the mental foramen is, the nerve is going to be mostly at the buccal part of it. So, just a little, again, guideline to keep an idea that the nerve itself is going to be most lingual at the third molar region where it's entering, and right down the midway of the mandible is going to be around the first molar area, and at the buccal plate or close to buccal plate around the premolar where the mental foramen is going to be. And the other tricky part about this is about, approximately less than 1% of patients might have bifurcation. So they might have two canals. And, it's very tricky to pick it up. But I've seen patients actually with two canals and they were running parallel and they end up actually having two mental foramen also, because each canal had its own mental foramen. So it's extremely rare, but we just also have to be careful that there's a possibility we can have bifurcation of the two canals. So understanding the transverse pathway of the nerve, realizing at the first molar it's right down the middle, and as you go mesial or coming anteriorly, it'll be more to the buccal side cortical plate, and if you go back distally, it'll be more towards the lingual side. Gives an idea of the 3D position of the nerve itself. The other important thing, and distance, again, these are mean numbers to give us an idea about the inferior avicular nerve, is the mean distance from the second molar apex of the second molar to the nerve is usually 3.7. The mean distance at the first molar is about 6.9 millimeters. So 3.7 millimeters at the second molar, 6.9 at the first molar, and at the premolar it's about 4.7%. So obviously you can see we have a little bit of more leeway at the first molar, and as expected compared to the second molar and the premolars. Another tidbit, mandibular canal has to be visualized in x-rays before implant placement is done. So no matter what kind of radiographic techniques you use, you have to visualize. If you're putting an implant in the second premolar, first premolar, or the molar area, either you have to identify the mental foramen or the nerve. If you cannot identify it, then you have to get a better radiographic picture to be able to witness where the nerve is, so you know for sure what is your length that you cannot violate. So again, if you have to take a CT scan, please do, but make sure that you are seeing the inferior avial nerve when you're true implanting that implant case. All right, so let's look at the CT scan because you can see from the skeletal point of view, and I've shown you a picture of it too. But at the same time, the beauty of the CT is it lets you visualize the whole path of the nerve, and once you kind of see it in the CT scan itself, and you can see the path it's going to, it's a nice picture that's set up in the back of your head and in your brain, and you can actually, looking at a 2D picture, can actually visualize a 3D because you see how the nerve was passing through. So here you can see that's her mandible. These are two mental foramens. So what I'm going to do is I'm going to estimate a nerve canal. Let's find it out. The first thing we do, we find our mental foramens, as we discussed this in our radiology lecture. For CT, here's one. And here's the second one. And then we're going to tag the other part here. And let's both canals. There you go. So you can see the nerve coming in on both sides where the mental foramen is. I'll confirm it. So let's see how it looks like. So you can see around here at the third molar area. This is the third molar area, and see how close it is to the lingual plate? And as it moves forward, it's going down pretty low in this case. And around the second molar area, let's find out what the distance would be. So this is the region. So in this case, it's about 5 millimeter from the apex of the second molar, and as predicted, let's see, it's about 9 millimeters or 8 millimeters from the first molar. So as predicted, there'll be more safety distance from the second molar compared to the second molar, the first molar. So you have more safety distance, and then at the premolar area, it's much closer. Okay. So again, you can see the pathway, and you can also see here, as it's coming in, it's close to the lingual plate, and the more interior we go, it's slowly traveling. And here you go. See how it goes to the buccal part of it, and the buccal plate, and you can see it exiting through the mental foramen. And let's look at on the other side, same story. Third molar, more at the lingual. As you go forward, it's slowly you'll see the nerve coming down to the buccal part. At the first molar, look how nice the distance is. It's almost 9. Let's look at how it was the second molar. As predicted, less than the first molar, it's about 3 to 4. And at the mental foramen, again, look how it's coming forward from being in the middle at the first molar, just like we talked about, and at the mental foramen area when it's exiting, it's coming to the buccal plate. There you go. That's a nice picture. So it gives you, again, a good idea of how the nerve is traveling path, being more lingual at the third molar area, right down the middle when it comes to the first molar, and at the buccal part of it. As you can see, right at the buccal part of it before it exits out of the mental foramen. And the other part I want you to keep an eye on here also is, remember we talked about the occlusion plane? So, it's pretty much a little bit above the occlusion plane. So if you're giving a block, in this case, right at the occlusion plane, the chances are you're going to miss it. So this patient has this mandibular foramen about 6 millimeters. Remember we talked about I like to be about 6 or 10 millimeter above the occlusion plane. Yeah, so it's about 5 millimeter on this side, about 6. So the nerve from here on in is inside the bony canal. So if your block was anywhere below this area, you would have missed the block on this young patient. The other very important landmark, and probably one of the tricky one, is the mental foramen. Uh, the mental foramen is where the inferior alveolar nerve exits uh, from the canal. So this is the inside. On the outside part of it, you can see the mental foramen. This is where the inferior alveolar nerve exits after it enters. So basically the pathway goes, it goes from the mandibular foramen, it travels the canal, transfers around the first molar, and then depending on anatomy, it exits either through the first, second premolar, in rare cases, the first molar. And we talked about, just to kind of repeat it again, the innervation from the mental foramen or the mental nerve would be the lower lip, chin, mucosal membrane, and gingiva all the way around to the second premolar and the incisive area. So again, understanding the variation based on race and ethnicity, but just to kind of give you an idea, in whites, the mental foramen is usually between the first and second premolar. In Chinese, it'll be closer to the second premolar. And in rare cases, you'll find the mental foramen at as front as canine or as back as first molar. Okay. So one of the studies that I really like and kind of helps me out to have a nice picture is the relationship from the apex of the premolar to the mental foramen. And why is that important? Because think about it, when you're doing, let's say you extracted number 29 or 28 and you're trying to do an immediate placement, and you're trying to go about 2-3 millimeter beyond the apex to get good solid bone, extra solid bone, to be able to have that primary stability. Well, it does matter where the mental foramen would be compared to the apex, right? So at the first premolar, 38.6% of the time, the foramen was coronal to the apex. That means it's above the apex. So if you're trying to achieve that extra bone, you're not going to do that. For 38%, almost 37% of the patient at the first premolar area. Right at the apex, the mental foramen is 15.4 and 46 is below it. At the second premolar area, the numbers are pretty much same way, where 24.5% is coronal, 13.9, almost 14 at the apex. The mental foramen is at the apex, and about 61-62% is below the apex. So, for us, that's just good numbers in your head to kind of figure it out. So in both cases, majority of the time, even though it's below it, we still have to worry about this number. And how do we know where are either this ballpark or this ballpark or this ballpark? And again, using our radiographing evaluation, we be able to, as we talked about in other chapters, we can have a good idea where that number would be. When for me as a surgeon, if I need to, I usually make a nice flap and actually visualize it where the mental foramen is going to be. And what I do is I actually visualize the mental foramen and measure the distance, clinically. And then I can make a assumption that, hey, which implant size or length would be best for this case. And if I'm doing an immediate, is it worth going into that extra bone past the apex, and which category it would be. But if you don't feel comfortable and you haven't made flaps, obviously you have other ways to do it, like we talked about in our radiology section part of it. So let me pull up a CT scan. So here we're going to take a look at the mental foramen, and you can see on the right side it's pretty much at the apex of the second premolar, and on the other side, again, let's see, a little below, because it opens up here, and you can see the root comes down like about a couple of millimeters below the apex. So again, this gives us a good indication. If you're doing immediate placement over here, obviously you don't want to violate that, because you can actually measure it from here on what the length would be, and you don't want to go bypass that part. So you can see as it travels from middle to, and it leaves the mandible itself through the mental foramen. So again, from a CT scan, you can visualize, and here you can see it also. Excuse me. There you go. You know, nice picture. The two mental foramens right here. The other tricky part about the mental foramen and the inferior alveolar nerve is that we have what's called the anterior loop of the mental foramen. And what is that? So you see that inferior alveolar nerve when it comes in, and you know, it doesn't just go straight up and exit the mental foramen. There's actually, it goes past the mental foramen, comes back, and then exits it. And I'll show you, you know, I have a patient that I took out to show you the CT scan of, but again, you can see it kind of comes from the bottom, goes up, and then comes back in, and then exits. So why does it make a difference to us? Well, the reason it'll make a difference to us is because clinically, if you're looking at it, and let's say if you make a surgical flap and you found the mental foramen and you're trying to place the implant at the first premolar area, you're like, all right, you know, the mental foramen is up here, the nerve is probably behind it, I can go maybe deeper and closer up here, but that's not what the case is going to be. What I do expect is as the nerve goes by from the bottom up, it actually makes an anterior loop and then comes back. So it goes forward and then comes back and exit. So the assumption is that, hey, the nerve is actually coming here and behind. No, the nerve is actually, depending on the mean average, you know, for me it's about 6 millimeters. That's what I always assume the loop it's going to be if I don't have the CT scan in front of me. One of the things, the other thing you can do, if you can actually make a flap and take a probe and hug the buccal plate and kind of really feel the depth of the canal itself. Again, if you're not comfortable, I don't recommend it at all. But at least for me, that's, you know, when I didn't have the CT scan, I would actually probe it and to see where it is, and then do my implant in that area. But for our purpose here, let's see. Oh, sorry. Okay, so that anterior mental loop, that's what we're going to call that little curve that comes in. The interior loop of the mental foramen refers to the inferior alveolar nerve. So obviously it's the continuation of the inferior alveolar nerve. When it crosses inferiorly and anteriorly to the foramen and then loops back to emerge from the mental foramen like we talked about. The anterior loop presents challenge when placing an implant mesial to the foramen, like we discussed when I showed you on the cadaver. So, you know, depending on the periapical, depending on the mental foramen, you know, there's really not that many good studies, especially if you're using pan. They're very hard to pick up the anterior loop on the pan or periapical. So that's why it makes it very tricky using those two guides to be able to place, you know, implant around the premolar area. So we always suggest to be above the mental nerve because it's really hard to predict that loop. So if you're above it, you have a good chance to be safe because the loop itself is always going to be below the mental foramen. The visualization of the mental foramen and using the curve probe, that's what I have done in past when I don't have the CT scan, is a good asset anteriorly to kind of gauge how far the depth of the anterior loop is going to be. And like I said, it's about 5 to 7 millimeters. So if you are 5 to 7 millimeter anterior to the loop, you want to be beyond that to be in the safe zone. If not, I would recommend your implant to be above the mental foramen, especially if you don't have direct visualization or you're not using the CT scan. So 6 millimeter is the minimum distance from the anterior aspect of the mental foramen. So what does that mean? That if this is the mental foramen, you want to have about 6 millimeter anteriorly, and you don't want to cross this line below this line. So 6 millimeter anteriorly you want to stay above, and after the 6 millimeter you should feel comfortable going below the mental foramen. So let me pull up a CT and give you an example. Alright, so this is one of the cases I picked out for you guys so you can kind of see the loop. So you can see the nerve Again, just kind of recap a little bit too. Occlusion plane, the mandibular foramen is above it. So if you were giving a block anywhere at the occlusion place, you will miss on this patient. So as you see, it enters about looking about 8 millimeters above the occlusion plane, and it goes through. Let's track it down so it gets, again, good visualization. Really helps it out. So it's coming in, and it's at the lingual part of it, as we talked about, at the third molar area. And as it coming forward, it'll slowly come more medial, and around the first molar, you'll see it right below the first molar. And then at the first premolar, the nerve comes out, right? But as you can see, it's looping out. It goes from down to up, and while it's going up, it goes right down to the buccal cortical plate, and that's where the mental foramen is. So you can see it kind of coming out. So you can see there's a nice loop around here, and let's kind of measure it, the length of this loop. So you're looking at from here about here. So it's about 4 millimeters, 5 millimeters approximately anteriorly. So if you're, let's say, hypothetically placing an implant over here, you know, you want to make sure you are above the mental foramen area, but around here, you can pass this area because you're clear of the loop itself. You can also see, let's look at the distance between the apex. So this is the apex of the tooth, and look at it, it's right at the mental foramen area, and there you go. So in this case, it's above, like a millimeter or two above it. So the goal of this is, I'm trying to show you the CT scan. So even though when you are seeing a 2D image in your panoramic or PAs, I want you to visualize what's going on in 3D, because now you can see how the nerve travels down inside, and you can go back to my slides and correlate with these numbers how the nerves at the second molar, first molar, and premolar is in averages away from the apex, and how when it comes out in the mental foramen, there's actually an anterior loop that you can kind of visualize in your own head. You might not see in the x-ray, but you can visualize it and stay about 6 millimeters anterior to the mental foramen to be able to be safe in placing your implant. So you want to be at least 7 millimeters, 5 to 7 millimeters anterior to the mental foramen, and that is the area you cannot cross down, because the loop is where is resided in those areas. So again, this is a good CT visualization of that anterior loop. Next topic is going to be about the mandibular incisive canal and the lingual foramen. And you can kind of see up here the incisive canal and the lingual foramen up here. And the incisive canal carries the nerve. It's the extension of the inferior nerve that, once it goes through the inferior canal and the mental foramen, there are branches that kind of go forward. So as you can see, this is the mental foramen. So part of the branches actually move forward, innervate the incisors, and then kind of go on the back side of it, and it comes out on the lingual part of the the incisors. So it's present in 86% of the cases. 18% of the time it reaches the midline. So in some cases, you will say almost about 80% of the cases where it does exist, it will stop before it goes to the midline. But in 18% of the cases, it actually crosses into the midline. And when it does, that's when you see the foramen actually forming in those patients. The recommendations are the implant can be placed without through to incisive canal. So, you know, in this cases, we really don't worry about the incisive canal. So even if there is present, you can actually go through it, unless the diameter is usually large. So, and the reason I'm saying is, let's kind of go back in that picture. I'm sorry, right here. So, you know, there's 2 millimeter numbers in my head. If the diameter of the foramen or the artery that exists these foramen are greater than 2 millimeter, I'm pretty cautious. Then I stay above this area. But if it's less than 2 millimeter, then there's less of a bleeding issue, less of a problem, and you can cauterize it or put pressure on it. It's easier to control if it's less than 1 or 2 millimeter, but beyond 2 millimeter, the bleeding becomes an issue. So, all right. So, like I said, the implant can be placed without uh, worrying about the incisive canal. And when you're making your osteotomy, um, unless the diameter is really large, then it can cause some discomfort, but that's unusual. You know, if it's that's unusual to find a diameter that big. In some case, there are some literature about persistent pain that can lead to implant removal. So if you have a patient who's consistently has pain, and then you take a CT scan, and you can actually identify a pretty big uh, lingual or I'm sorry, incisive nerve, then I would recommend to be above it. But in most cases, if it's less than 1 millimeter, you should be okay. The lingual foramen and the lateral canal can also be found, which can lead to bleeding as dissection is made in the lingual aspect, as kind of mentioned briefly. Then you should be cautious. And like I said, if the foramen artery is less than 1 millimeter and is in a stem, it kind of joins the sublingual artery up here. And if it's less than 1 millimeter, I would not worry about it. But if it's greater than 2 millimeter, then be cautious, and you don't want to tear it. The other vascular consideration, this is also very important, and I'll show you a little CT scan for this too. The submental and sublingual arteries are approximately 2 millimeter in average diameter, and like I said, if it's 2 millimeter, you should be worried about the tearing of the artery, because it can lead to quite a quick blood loss and very fast. One is derived from the facial artery, the other is from the lingual artery. The sublingual artery is found above the mylohyoid. So if you're looking at the mandible and there's a mylohyoid attachment, you can kind of see it as the X-ray groove. So the sublingual arteries, you'll find it above the mylohyoid, and the submental would be below it. But in either cases, they do pierce down and above, so you still have to be very careful. So the submental is below the mylohyoid about 40%. And like I said, it pierces through the mylohyoid percent. So again, even though I'm telling you it's above below, but just be careful because they do pierce through. But in some cases, so the importance is, in some cases, the sublingual and submental artery may course close proximity to the lingual plate. So as the artery travels, it's very close to the lingual plate, and there's a possibility that there are branches of this vessel that actually enters the lingual plate in this area as they're going across. Well, why is that important? Well, if we're placing an implant in that area around the around the first molar or second molar, and you perf through the lingual plate, there's a possibility that you'll be able to tear this vessel and damage it. And knowing the diameter of this can lead to a very fast bleeding. And since you are at the floor of the mouth, you'll have a nice big fast hematoma that could be life-threatening. So again, this is the key point here. You want to make sure you're not going through the lingual cortex, because either at the cortex or right next to it, you could have the submental and sublingual artery, and you can tear it if you perf the cortex and tear these arteries by themselves. And like I said, these tend to be about 2 millimeter in average, so you have to be concerned about and worried about a quick blood loss and an expanding hematoma that could be life-threatening in the mouth. So that's the cautious part. And I'll show you a CT, especially in old patients, especially in old patient, how deceptive the lingual cortex could be. and we have to be very cautious about it. And again, when we talk about our surgical protocol later on, and we'll show you how to we won't make that mistake. So again, to recap it, the penetration through the lingual cortex plate into the floor of the mouth while preparing an osteotomy for the implant can cause tear to the artery, which could result in an expanding hematoma that can be life-threatening. So caution should be made either while doing your osteotomy or doing a lingual dissection. So let me get the CT scan out. So I'm at the area of the second molar, and you can see, look at the shape, and it's a good cross section to see. This is our occlusion pattern, and this is how the teeth are lined up. And you can see the lingual plate kind of going in, and our next subject is going to be about the submandibular gland and the fossa itself. But to give you an idea, the artery is going to be sitting right here. So if you're trying to put your implant straight down, you're like, all right, I'm right vertical, and the axial loading occlusion right on top of the other tooth, but because of the shape of the mandible and the proximity, and look how thin the lingual cortex is compared to the buccal part, how thick it is on the buccal. If we perf this, there's a chance that the artery itself is passing through here, very close to it, and then tearing can lead a big hematoma on the sublingual part of it that you might not even see because the floor of the mouth is probably around right here, and then all you see is in a few minutes there's a big expanding hematoma and patient has a problem. So we talk about the mental nerve, the inferior nerve. This is the other very important key part that you have to understand. And later on, we'll help you guide through this part and how to protect yourself from here. So next, we're going to talk about the submandibular and sublingual fossa. And in both those fossas, you have the submandibular and the sublingual glands. So you can see this is the submandibular fossa, and then right anterior to it, you have the sublingual fossa. And there's a reason to be precautious about that too. So when you're looking at the mandible, for example, it's hard to kind of see it, but I'll try to. You can see the little kind of goes up and then boop goes deeps down. That's where the fossas are. So this is where the submandibular gland is going to be, and anterior to it would be the sublingual gland. But it's probably a better idea to show it on the CT scan. And like I said, for old patient, that becomes really tricky. But let's kind of go in a little bit more detail about these guys. So the submandibular fossa is a depression on the medial surface of the mandible. It's inferior to the mylohyoid line, and it contains the submandibular gland. So we just kind of went over that. The sublingual fossa is shallow depression of the medial surface of the mandible and is superior to the mylohyoid. So one is above, one is below. This is on the back side, this is on the front side. Both should be palpated. So, that's you want to feel that concavity and what the depth of that concavity is, and one of the better ways to is obviously to palpate it. This lingual concavity is due to the fossas could go up to almost 6 millimeters, so it could be very deceptive. So when you're looking at it from the top down, so if you're looking at it from the top part of it, and you're looking at the width of your crest, and you measure it, let's say about 10 millimeters. But what you don't realize that there's actually concavity that goes in as it goes down about 6 millimeters. So the actual length at the apex might be only 4 millimeters. So this is why it's pretty important to have a full scope of that depth or the concavity. And so when you're putting your implant in, you make sure that you're not perfing through the lingual cortex and piercing through the sublingual and submental arteries because you understand where the concavity is going to be. So palpating is very important because you can get almost about 6 millimeters of the fossa depth in there. If not accounted, like I just talked about, the ostomy can perforate the lingual plate and cause bleeding of sublingual and submental arteries, leading to threatening expanding hematoma. And CT is probably the best, obviously the most accurate way to picture it, but there are ways, and we'll share that when we do our surgical protocol, that you can accurately predict those concavities. So let me pull out a CT. So this is a little bit of an extreme case, but again, I want you to see it because you'll see that in the patient, and it's always nice to visualize these things in your head. Like I said, the key is to, even though you might see a pan, but after having this picture, looking at the CT scan, you can close your eyes and kind of predict the 3D part of it by adding your, when you're palpating that side of the lingual, you can close your eyes and I almost feel and correlate with what you see right now into what you can put a picture in your mind and be a better clinician because you understand what the anatomy is. And it's like I said, it's extremely important. So you can see at the laterals, how straight the mandible is, and right next to it you get that little um, small sublingual part of it. But look what happens. Look at that. Look at the depth. This is the part, and look at the depth of the submandibular fossa. You're looking at around 7 millimeter, and it gets even worse and worse as you're kind of going back. And look at that. Let's measure it. It's almost 9 millimeters. So again, like I said, it's a pretty dramatic, and this is on the extreme side of it, but it is something like that. So like I said, almost 6-7 millimeters of the depth. And if you're trying to find occlusion and trying to place your implant straight up and down, there's a chance you might perf it if you're putting it straight down. Obviously, the alveolar bone would be up here, but this is what you have to be careful about. And let's look at the other side. Look at that. Again, this is pretty normal. You'll see this a lot when you're going in the mandibular, in the posterior. This is the concavity. So if I go straight down, because this is what you're visualizing. You look at this crush, you're like, oh my God, look, I got 13 millimeter. I can put a huge implant in here. But in reality, almost half of it, about 6 millimeter, like we talked about, there's nothing there. So you want to put your finger in this area and palpate it and try to feel it. Hey, exactly how much do you have? Obviously, if you don't have a CT scan, and then close your eyes and then kind of picture this right here. When you put your finger in this area, that this is what you're doing. Your finger comes in and palping this area, and you can tell yourself, hey, I can tell now about 6 millimeter of just a ridge on the top. And just a quick note, why do we get this shape? Beside this depth right here, why do we have this bone loss mostly on the so this is the buccal part, is the lingual. Why we still have that cortical attachment on the lingual, but we lose pretty much all the bone in the buccal, the alveolar bone? Well, part of the reason is you have those muscle attachment, right, on the lingual part. So that help keeps this bone active, and that's why you still have that bony part of it. If you lose that muscle attachment, you would have lost this bone also in that area. So again, this is a pretty big important part where we talked about the mandibular fossa, how it can be deceiving in projection of the width of the crest. So you come in, you're looking at the width of the crest, you're like, all right, that's a lot, but in reality, you got to there is that submandibular fossa deficit that you have to fill. Okay. Now the next part is the lingual nerve. It's also extremely important, and this lingual nerve is one of the other reasons I tell all my doctor students that, hey, do not make any vertical releases anywhere in the lingual area, because it varies a lot, the lingual nerve. It can be as high at the crest or even below, very close to the lingual plate itself. So our recommendation is never ever in the mandible make any vertical release. What's a vertical release? Straight down. You can do that sulcular part, but never go straight down. No vertical release on the lingual part. Big no, okay? And most of the reason is because of the lingual nerve and the artery too, obviously. But let's look at the lingual nerve. The lingual nerve provides a sensory innervation to the mucous membrane of the anterior two-thirds of the tongue and the lingual tissue. The lingual nerve is usually located about 3 millimeter apical to the osseous crest. So 3 millimeters, if this is the crest, 3 millimeter below it. And from the lingual cortex plate. However, in 20 to 15% of the cases, the nerve may be actually above or at the lingual crest. So when we're making our third molar incision, this is why we do what's called a hockey stick incision. We're very buccal. So if you have a third molar, so let me kind of show it to you. So if this is my third molar area right here, my hockey stick incision would be right down the middle and going to the buccal. So it kind of comes out at the buccal, little hockey stick, straight down in this area, and we never cross this midline and go in the lingual part because of the lingual nerve. 20%, 22% of the time, the lingual nerve may contact the lingual cortical plate. So think about it. If it's at the contact 22% of the time at the lingual cortex, then you have to be careful about perforating the lingual cortex. So you have two things to worry about now, not just the bleeding from submental sublingual artery, but also the nerve damage that can cause because this guy hugs the lingual cortex. And like I said, the incision distal to the second molar should be very careful, and when you're crossing the midline area. That's why we do the classic hockey stick incision for our third molar extraction, because we want to stay away. The hockey stick part of it is away from the lingual part. We're going at the buccal. And like I said, that's why not just recommendation, it's one of the absolutes, no vertical release at the lingual area whatsoever. Next is the mylohyoid nerve. This is the one we usually don't worry about, but just for our going through the anatomy purpose, it's a branch of the infraalveolar nerve. It arises just prior to where the infraalveolar nerve enters the mandibular foramen, so it's way in the back. You should never be countering it. If you are, we're in trouble. It innervates the mylohyoid muscle. The nerve may also contribute to accessory sensory innervation to the anterior and the posterior mandible teeth. The anesthesia consideration for patients. So sometimes if you give a mandibular block and the patient is still kind of jumps as soon as you grab the tooth and they're jumping. This is sometimes from my anecdotal experiences is the mylohyoid. So at the apex of my molar, I just kind of right at the apex on the lingual, I'll inject a little bit of lidocaine to kind of desensitize the mylohyoid nerve, and we have a good response, and patients tend to feel better. So unless you give a Gauge and block the whole V3, you can give a little bit of it at the apex and actually take that sensation away. The long buccal nerve, it's a branch of, again, the mandibular V3. The sensory innervation to the buccal gingiva, the mucus of the cheek, and the retromolar area is basically behind the second premolar. And I'm sure you guys do that when you're giving if you're doing any extractions, and especially in the molar area, you want to give the long buccal. The course underneath the masseteric muscle to connect with the buccal branches of the facial nerve on the surface of the buccal So this is how it kind of travels down. So we're really not, you should not be encountering it when you're making your incisions. So next we're going to talk about the musculature, and there's really not much to talk about when it comes to the implant dentistry. One of the ones I will talk about is the mentalis muscle. And the reason I'm going to talk about the mentalis muscle is because sometimes when we're making flaps, we tend to dissect this muscle out and cut it through. And you have to be careful, because if you completely deattach this muscle, you have to worry about, it's called the Witcher's chin or the double chin, because the muscle is kind of hanging through it, and you kind of basically cut off his insertion point. So at least for me, when I do make my flaps anterior up here, I always make sure I leave part of it still intact, so either I can suture it back or it's still intact up there. So, just be careful with your mentalis muscle when you making a flap on the interior in front of your two premolars, to leave some of the mentalis tendon back. Otherwise, you're going to have this nasty Witcher's chin part of it. So this kind of concludes our mandibular portion of the anatomy, and these are the two nice pictures. It shows you where all the muscle attachments are in the blue part of it, It talks about the mylohyoid muscle, the submandibular fossa, and the sublingual fossa. To give a good idea of what we talked about so far, the mentalis muscle, the mental foramen, and the facial artery is important. You don't have to worry about that because you won't be encountering it. So again, this is a good couple of pictures, but again, this is very important. As you can see, with the help of the CT scan, you should be able to have a picture in your head now. We did some review studies and literature studies to give you some numbers to back it up. So you have some idea. We talked about that unique anterior loop, 6 millimeter anterior to it. You should not go below the mental foramen. And even little hints like when you're giving your block, try to be a centimeter above the occlusion plane. And now you know why, because we talked about the studies, the mandibular foramen and its position. So next we're going to talk about the maxilla. So if you want to take a break, go right ahead. So now we're going to talk about the anatomy of the maxilla. The maxilla has its own unique challenges. And we're going to talk about, especially on the interior of the maxilla. And when we talk about placing of the implant, and later on we'll talk about guard classification on when do you think you should be ready for tougher and harder cases. And I'm telling you from my experience, the interior of the maxilla, just because of its anatomy, makes it extremely challenging place to place implants, and especially the area where your patient is looking at it every day when they're smiling, and everybody's making comments on their smile, and they're giving you money and their trust to fix that area. So, later we talk about it when you should start feeling comfortable starting doing those type of cases. But the interior of the maxilla presents a very unique challenges. But in general, today we're talking about the anatomy part of it. So, just the soft tissue. This is what makes the maxilla unique too, because of the palate and the tissue on the palate. But just to give you an idea, the gingival thickness around the area in the maxilla on the buccal side, you'll see about 0.53 to 2.63 in the range. The mean is about 1.56. The palatal is almost double. So because it's nice and thick and has a strong connective tissue and the rete pegs around it to give it that 2.8. So that makes the maxilla unique. The best place to harvest, for me at least, when I do my tissue grafting, is around the palatal part of the canine and premolar. The thick graft usually is at the gingival margin, but it gets even thicker when you're trying to get to the mid part of the palate, the midline of the palate. The tuberosity is where the thickest is 5 millimeter. There's a lot of redundant tissue over there. And the thickness of the palatal graft, and I use my probe to literally kind of pierce through and hit the palate to kind of figure out exactly what kind of graft and what kind of tissue I'm expecting. So the first thing we're talk about the infraorbital foramen, and when we're giving a blocks, this is one of the blocks I give to basically anesthetize the canine, the lip, and the centrals. The infraorbital foramen contains the infraorbital nerve and the blood vessel. It's under the pupil of the eye, about 5 to 7 millimeter of the infraorbital rim. So, excuse me. So if you're looking at the infraorbital rim, here's an example. It's about a 5 to 7 millimeter from the infraorbital rim. You have the infraorbital foramen, and that's where the nerve innervates. And the other way, it depends on, again, well, like we talked about, there is definitely variation, but usually it's at the canine area. You kind of make a line down the canine area where the foramen's going to be, and later, if you go even below the commissure of your lips, the canine and the infraorbital nerve tend to be on the same line. So that's, at least for me, that's my landmark for this. So when do you have to be careful about? Well, obviously when you're reflecting your flap up, you have to be careful not to impeach too much, otherwise patient will have lack of sensation on their upper lip and they will complain for a while. Excuse me. The incisive canal and the greater palatine foramen, again, those are the, we're talking about the incisive canal and the greater palatine. The greater palatine is what you have to really worry about, because once this starts bleeding, it is almost impossible to stop it. And again, I will give you some guidelines about it. So when you're looking at, let's see if I can give you a good view from it. And there's a lot of variation to it. You can see a nice big opening of the incisive canal here, and the greater palatine would be coming out from about here. Okay, let's put it back. All right. So from our literature review, to give you an idea and a picture in your head, the content of the foramen are the descending palatine vessels and the nasopalatine. This foramen is about 4.6 millimeter wide and is located about 7.4 millimeter from the labial surface of the unresorbed bridge. So you're marking your so this is your unresorbed bridge, and you're looking at about 7.4 millimeter away from the, I'm sorry, there you go. So this is your unresorbed bridge right here, and you're looking at about 7.4 in average millimeter length away from the unresorbed bridge. So it's right here. The length of the nasopalatine canal is approximately about 8.1 millimeter, and it exits to the nasopalatine foramen. Large incisor canal could be an obstacle to implant placement in the central incisor region. What does that mean? So what that means is basically that if you have a canal and it's a pretty wide canal up here, that's the nasopalatine canal. And if it's wide enough, that means the nerve is passing through is going from here into the nasal area. Then when you're placing your tooth central, you might be violating that nerve and the artery up here. So it could be a problem, and there are times we face it. What I usually do is I pretty much actually open that canal up, enucleate out the nerve, the artery, and I actually pack it with bone and place my implant. So again, if you don't feel comfortable, don't do it. But again, in advanced stages, being a surgeon, we have the good comfort level in be able to nucleate the nerve out, pack it with bone, and put the implant in. So, but there are other ways to do it. You can actually move the content right or left where you're putting the implant, but like I said, I can actually clean it out and do the bone graft, and in some cases you can even angle the implant away from it, but I've seen some really big incisive canals in that area. The incision of the content usually have minimal to no effect whatsoever, but in rare cases patient will complain about the numbness of the interior of the palate. Again, it's in very, very rare cases, and most of the time, after a month, patient doesn't even realize it as being an issue. Like the inferior alveolar nerve in the mandible, the biggest concern is the greater palatine foramen and the artery that comes from the greater palatine. So, bunch of 4 stars. The posterior maxilla needs to be treated with extreme cautions in the palate as related to the palatine foramen. When we do our big reconstruction surgeries, I've seen some pretty nasty bleeding from the palatal foramen, and especially at the area where it's coming out from the foramen, because it's nothing to tie down. I mean, it's a big hole in there, and all you see, an aggressive fountain of blood just coming out. So be careful. And then, like I said, you shouldn't be in that area in the first place. But I'll give you some good numbers and some good ways to give you an idea where this is, so you're kind of out of the territory. So anyway, it contains the greater palatine artery and nerve, and transverse anteriorly, and it joins the nasopalatine branch of the sphenopalatine artery. So basically, let me kind of give you an example. So the greater palatine starts out in the back, comes transversely closed. It actually joins the nasopalatine artery, which itself then joins anteriorly into the nasopalatine artery. So that's the course it's going through. So let me kind of go back. The foramen itself if you're looking at the foramen itself, it's let's take a look at it again. The foramen itself, about 86% of the time, it's right next. It's at the area of third molar. Okay, so if this is the third molar, you'll find the foramen at the area of third molar, and only 1% of the time it'll be around the first molar. So most of the time you'll be at the third molar, then a little bit of 10-12% in the second molar, and almost none in the first molar. So whenever you at the palatal part deep down third molar, this is what we have to be careful about, the greater palatine artery. The distance from the gingival margin to the greater palatine artery ranges from 12 millimeter to 2.9 or plus 2.9. So that means either 10 to about 15. So about from 10 to 15 millimeters from the gingival margin around the third molar area, this is where you're going to find your greater palatine. So kind of go back. So again, so you're looking at about 12 to 14 millimeters. So if this is the gingival margin, let's say, if this is the gingival margin, it'll be around 10 to 15 millimeter, 14, 15 millimeter from there. So you can actually have an idea and measure that and make sure you don't pass that part. And same thing. And when it is to the second molar, it's actually going to be even more of a distance. So you're looking at plus or minus 3, so 17 to 11 in the second molar area. And sorry about the canine, that's a mistake. The location of the foramen in mean distance is of 16 millimeter from the center of the greater palatine foramen. So the location of the foramen in mean distance of 16 millimeter from the center of the greater palatine foramen to the mid-sagittal plane of the hard palate. So what they're trying to say here is that if you're looking at the mid-sagittal hard palate, the other way to measure would be you take the straight line at the third molar area, right? And you go about 16 millimeter here. And that's where your mental foramen is going to, the greater palatine foramen is going to be. So from the mid-sagittal, you have about 16 millimeter on either direction where the greater palatine foramen is going to be. So, like I mentioned before, tearing or severing the palatal artery close to the foramen can cause a big problem, and it can really proceed back to the bone, and then it becomes another big problem because there's no way to tie it up, and it's a big mess. So, again, easy way to remember would be you get the mid-sagittal plane and 6 millimeter from it where you're going to find it, and mostly at the third molar area. So again, just a pictorial recap. So if this is your mid-palatal plane, you see about 16 millimeter down here, or about 12 to 15 from the gingival margin. Okay, so that's what you're looking at. The other thing that can affect the placement of the palate is obviously also the shape of the palate, because you could have a rounded, very shallow, a very deep V shape, or in some cases a U shape. And based on that, depending on the shape of the vault itself, the palatine artery could be 7 millimeter. If it's flat, it makes sense because it's now closer, right? It's flat, so it's closer to the gingiva itself. And if it's V-shaped and it's, you tend to be a little bit farther away because the palatal is more back up. The next part we're going to talk about is the incisive canal. The incisive nasal spine. And again, it's, you can see it right here. It has a support for the nose itself. This is your central, and it kind of goes back, and you have the nice nasal spine. And when you're dissecting, you don't want to pass this nasal spine, because beyond that, there's nose, and it's extremely vascular, and a little nick in there can lead a lot of bleeding. So as soon as you are dissecting up and you feel that little bony protuberance right here, this is the picture I took right here, you know to stop, because now you're going into the nasal part of it. So it's right under the nose, it's in the midline, sharp bony projection, and it's a landmark. So if you're flapping it out and you want to see that concavity, which makes the maxilla such a hard place to put an implant in, because it's straight unlike the mandible, it's not straight up and down. There's a hour-shaped glass concavity up there. So be careful of that part of the nasal spine. So what I'm going to do is the three things we talked about right now. Let's look at the CT scan, see if we can pick it up. All right, so in the maxilla, while we do our cross section, this patient, we just took the CT of the maxilla too, so I can share with you guys. So let's find the nasopalatine or the incisive foramen. Let's see where it is. There it is. Okay, so you can see, remember the hourglass I was talking about? Just like the mandibular fossa you have in the mandible, this is kind of like a mandibular fossa kind of effect that you have over here. It's easier because you can see it. If you flap it down, you can actually see that depth part of it. But again, we'll talk about it where sometimes when you don't want to flap it down. This is the nasal spine we're talking about. You can see the outline of the nose, and it's kind of supported by the nasal spine. If you pass that, as you're dissecting your flap, you're pushing it back. But as soon as you feel that going up, stop, because you don't want to perf through that. But here you can see the nasopalatine or the incisive foramen. And you can see how it's kind of wide enough. It's not that bad. I have much worse. I've seen it. So now look at it. If you're taking this tooth out and you're putting the implant in, you're more than likely going to run into the fossa itself. So what I've done is I just kind of nucleate this area out, put bone graft in, so I'll have a good part. But again, these are advanced cases. But at least, if you're not planning to do it for a while, but at least you have a good understanding what to do and what to stay away in these cases. All right, and now you can see the greater palatine, right? Third molar, like we talked about it. The distance is about 9 millimeter here, but this is the greater palatine. You can see, boom, right there, coming out. Okay, so all those three maxilla we talked about. Let's come back here. Here's the incisive again. Mandible, the nasal spine right there coming out. So hopefully with the help of the CT scan, again, even if, I want you to really have an idea. So even when you look at the 2D, you can visualize what a 3D would look like with the help of the cadaver and the CT scan. All right. The next part we have to talk about is the maxillary sinus. The average height of the maxillary sinus from the floor of the maxillary sinus to the superior wall, which is the orbit itself, it ranges from 36 to 45 millimeters. The width is about 25 to 35, and these numbers make a difference when you're doing sinus lifts, obviously. The mesial distance is about 28 to 45 millimeter. The maxillary sinus floor is approximately 10 millimeter below the nasal floor. So, that's a good thing to also understand is because when you're looking at the nasal floor, the maxillary sinus actually goes down below the nasal floor, almost 10 millimeter. Okay, so that's a good thing to remember also. The sinus floor could be in between the maxillary molar roots, and I'll have a CT to show you, kind of explain you what that means. The septa has been located in 31%. Well, what is septa? Septa is that divides the maxillary sinus into a couple of chambers, in two chambers. So septa has been located in 31.7% of the maxillary sinuses, and it's usually around the premolar area. Okay, so if you have a big one maxillary sinus, it's sometimes divided into two by the small thin bone called septa, and usually you find them at the premolar area. The maxillary sinus, the Schinderian membrane is covered, so it's covered by the Schinderian membrane, and the thickness of the membrane is, as you know already, is 0.3 to 0.8, so it's very thin. So whenever you're taking out that second molar and the palatal root, the bone is very thin on the old patient, and you can see the membrane and tear of the membrane. So keep that in mind. But let's look at the, I'll go over the CT scan and kind of give you a good anatomy of the maxillary sinus. All right, so here's a CT scan, and the first thing we talked about it how from the nasal floor, approximately that's where the nasal floor is, it's about 10 millimeter, the maxillary sinus. So you can see this is the depth of the maxillary sinus, about close to usually 10 millimeter. If there would be a septa, what would a septa be? So if this is your maxillary sinus, and you can see this big cavity inside, there'll be a bone right here. That's pretty much dividing the two chambers up here, and there's about 38% of the time you'll see the septa. The other thing you want to be what we're talking about is, like I said, this is the cross section. Take a look at it. Look how the roots are spread apart. Okay, and you see the bone kind of dips down and back up again. And sometime when you're reading the panoramic x-ray, for example, and you're looking at it from this side, you assume the bone level would be like this because you can see all this bone, and you're looking at the pan, you know, this area is kind of camouflaged because there's bone before and bone after. But the real level of the maxillary bone would be from here to here. So it could be deceptive when you're trying to, using a pan or a PA, try to measure your bony height, because this is the bone gets overlapped in the back and you don't realize as the bone are nicely hugging buccal and palatally part of it. So it's a kind of key component of it. And obviously you can't see in the CT, but the Schinderian membrane is the one that covers up the whole sinuses, and its primary function is to clean it up and pass it to the ostium, which would be here, and then it goes into your nose and back of your throat. So that's how the sinus function would be part of it. So again, let's look at the other side. There you go. You can see the nice spreading of the molar area. All right. So this is a young person. Let me look at the old person. I'm trying to show you the anatomy comparative with a young and an old person. All right. So remember we talked about the. This is the the patient was, I believe, in his early 70s, and I just want to kind of show you. And I just want to show you how the bone changes as you get older, because remember we're not ever dealing one age bracket. You're going to see young people, middle age, and then old people. And beside the anatomy what we talked about, and we're trying to put everything under the one umbrella, but it's not. As you get older, the aging phase has its own clinical aspect that you have to be concerned about, and I'll go over that in about a minute. But I'm going to recap from the back a little bit. And remember we talked about the incisive foramen you saw in the young patient. Look at this as incisive foramen. I mean, that's huge, right? So you can almost predict in this patient that when you're about to do your implant, that's going to be a problem. But not just that, the patient has lost a lot of his alveolar bone. And, I'm going to show you a picture of a young CT scan in here and the old, and you'll see how much bone loss and what difference does it make. So this is an example of a huge incisive foramen, for example. And right here on the posterior of the mandible, let's go back on each side. Oops, sorry, let me go back on here. This is where the submandibular fossa is going to be, and this guy is actually, for his age, he has pretty good bone. Most of his problem are in the maxilla, where once you start losing tooth, look how the bone has remodeled itself after the tooth loss. And in the back area right here, you can see how slowly where the remodeling is happening in that area, and it'll be making it almost impossible to put the implant in. So if you put the implant in according to where the bone would be, which would be around here, this is really protrusive and coming straight out. I mean, nowhere close to it, and that's because of all the bone loss the patient has gone through. And then in the middle, you can see the incisive canal and see how big an issue would that be. But still pretty good, but that's not much of a bone loss for a 70-year-old patient. So let me show you another one. Here's the other patient that actually had the Alum for treatment done on the top and bottom. But what I'm trying to show you here is you can see how much bone loss this patient has, how much sinus has pneumatized. And you can even see that when the tooth were taken out, these were the extraction side, and his membrane is a little bit inflamed, and you can see that's an inflamed membrane. You shouldn't be seeing it like the young patient, which I showed you. I almost had no inflamed membrane around it. So you have to be careful of the pneumatized sinus when you're going in the back, and look how small the bone is. I mean, there's literally nothing there. But if you looked at his x-ray below, you would have assumed the level of the bone would have been up here, right? Because you can see there's a bone right here, There's the bone right here, and when you're looking at an X-ray, which is coming from this point, and looking through here, this whole part, it gets kind of distorted or camouflaged because you have bone here. It's like a superimpose. So, you know, from the X-ray, you'll be like, all right, I got about 8 millimeter. Maybe I can do internal sinus lift, just bump it up. But no, this is literally nothing, and it would have been a big surprise. So this is very hard to see it on the pan and the PA, but the CT kind of gives you a good idea. But now, even if you have a pan and PA, keep in mind that, you know, the bone you see might not be what you find because the displacement or the spreading of the roots can superimpose from a PA pan and kind of distort the image. All right, so next, oh, sorry. Next thing I'm going to talk about, and quickly, but again, we kind of went over the CT and we discussed some of this part already. But again, for visualization part and understanding part, that you're not going to see the patient. You're going to see this. This is what you're going to see. You're going to see young people, middle, and old, and the bone changes from each part of it. And the second part about the anatomy, and as important as the anatomy is, that you should be able to predict when you see the young versus the old, what changes are going through, how your numbers are going to change, and how your treatment plan is going to change because your anatomy is actually going to change. You know, it's not the same person. It's same the person you saw, you know, Susie that you saw 10 years ago or 20 years ago. It's not going to be the same Susie when she comes to know, and her anatomy has changed a lot, and you can't predict the same way. And you know, one of the ways you can have an idea what kind of a loss you get is once patients who have no teeth, right? When they have lost teeth, you can actually see the bone loss. So the alveolar ridge actually goes down when there is no internal loading and the bone actually turns over and you're losing bone. And you're actually starting to see also on the buccal part the cavity, which makes it challenging. Obviously, in the back, if there is no tooth there and no loading, you will start losing the bone height. And that same mental foramen that was down up here slowly is now creeping up and making it almost impossible to put the implant in. And same thing with the inferior nerve. Same thing on the interior of the mandible. And you know, if this is the interior, the canine region part of it, you can see this is how you start seeing the bone loss, where you know, the extraction, you get the little you know, the mountain part of it, the peak of the mountain, and then slowly kind of goes down, rounds itself off, and all you left is the cortical bone. So you're losing that alveolar bone, and then you kind of end up getting just the inferior white cortical bone part of it. And you know, again, another nice picture at 30, 45, 60, 80. So it's not just the bone. You can even look at your patient, right? If you see that chin coming in, that acute angle of the chin, that means that alveolar bone right here, which was nice and straight, is gone. You know, because once you lose that alveolar bone, all this muscular just collapse down, and then you get that acute angle. So when you see a patient coming with an acute angle, you know she lost, or he or she lost a lot of that alveolar bone up here. Okay, and again, the more older you get, the more of that collapse you get. And same thing happens in the lip part, where you see that nice obtuse angle right here, and then all of a sudden when you lose, acute angle right here, and then as you get older, it becomes more obtuse, more bigger and wider, because you're losing that lip support and the alveolar bone again. So sometimes not just a radiograph, but just by looking at your patients, you can be able to predict what kind of bone loss they have by age. And this is the back of the maxilla. You can see A, B, C, D as they're going back. You can see the atrophic of the maxilla as the patient is aging. And you know, the palatal part is usually there is the alveolar part on the buccal that you're kind of losing slowly. And then because you're losing at that, you know, this is not, when you have this doesn't mean that it's equally lost from the palatal and the buccal part, and then the straight part is left. No, that's not how it works. You know, the buccal part is losing more bone and the palatal is still there. So that distorts the placement of the implant, because this part is pretty much just this part. Okay. And then same thing with the mandible, and you can see um, this is the buccal part, this is the lingual part, how this is the angle, but as soon as you get older, you're losing that angle completely. And then if you go back, sorry, when you lose it completely, it collapses down and you can see that chin coming out. And then just keep that in mind. Sorry, I'm jumping all over the place. That, so when you're placing your implant in this type of bone, you can be pretty straight down. But as you get older and older, that you have to worry about the angulation, which side it's going to be. And again, even in this area, you can see when you're losing your bone, it's not like you're losing on these buccal and lingual equally. Part of it is mostly at the lingual part that you're slowly attached. Mentalis is keeping you healthy there, but the alveolar bone is gone on the superior part. All right, so this concludes our lecture on anatomy, particular to implant dentistry. Like I said, for me, personally, this is probably one of the most important lectures that you're going to have here prior to surgical protocol. Once you have, I want you to go over this lecture over and over again, get those numbers in your head, look at those CTs, and close your eyes and just start picturing it. Put your hand in patient's mouth and palpate the lingual part, the fossa itself, and then close your eyes and just start imagining a 3D picture in your head. And the more you practice at it, the more it'll make sense. And the more of those numbers that we talked about, from the apex, the mental foramen for the premolar, all those numbers, they're going to become a habit because now you have a clean picture in your head. All right, so again, thank you very much.